Hello, and a very, very warm welcome to today's ISNTD Connect session. It's a pleasure to welcome you here today with around the World Antimicrobial Resistance Awareness Week in full swing, where countless partners are coming together to really shine a spotlight and raise awareness about antimicrobial resistance. What does this mean to global health in general? So it's our pleasure today here at ISNTD to take a closer look with our wonderful speakers here on screen on this really pressing issue, which, whilst the tone of the week is very much in a positive light and with a lot of collaboration and momentum in it, let's not forget that antimicrobial resistance was by WHO itself listed as one of the top 10 global health threats to human health, that this touches upon animal health, the environment, food production, and many, many other fields. As some of our audience will know, the neglected tropical disease approach and the strategies really rely very heavily on chemotherapy. Antimicrobial resistance is starting to appear in certain places. What do we need to know? How do we need to keep track of this? And what partnerships really are essential into understanding, preventing, but also responding to this growing threat? Those are some of the issues that we're going to take a closer look at and hopefully unpack with our wonderful speakers here today. And so without any further delay, it's my great pleasure to welcome on screen our colleagues from around the world. We will be hearing first from Professor Karen Barnes. Welcome, Karen. Thank you for being here. Karen, you are Professor of Clinical Pharmacology at the University of Cape Town. You also lead the Mitigating Antimalarial Resistance Consortium for Southeast Africa. Thank you so much for being here today. Our next speaker will be Professor Marc Mendelson. Welcome, Marc. Marc, you're Professor of Infectious Diseases at the University of Cape Town. You also lead the Trinity Challenge on Antimicrobial Resistance. Thank you so much. Dr. Jaishree Raman, thank you for making time. You're Principal Medical Scientist at the South African National Institute for Infectious Diseases. You lead the Antimalarial Resistance Monitoring and Malaria Operational Research Laboratory there. Thank you for being with us. Dr. Leah Moriarty, may I also welcome you very warmly. You're from the malaria branch of the US CDC and PMI, and you lead PMI's Antimalarial Resistance Monitoring in Africa. Thank you for connecting from Atlanta. And our final speaker will be Professor Arjun Dondrop. You are an ICU and infectious diseases physician at the Mahidol Oxford Clinical Research Unit in Thailand, and you're also with the Amsterdam Institute for Global Health and Development, whilst also chairing the Regional Steering Committee of the Regional Artemisinin Resistance Initiative. A huge amount of expertise today over the next 90 minutes. If you are in the audience, please, I think you know the tradition well, go on the chat. Feel free to tell us your name, your affiliation, which country you're connecting from. We're going to have a discussion after a few presentations, and we'll be, of course, more than happy to hear your comments, your feedback, maybe sharing some of your work, and also asking any questions that may come up during the presentations. I think it's really important to have these discussions because whilst AMR might be considered to be really about antibiotics, the neglected tropical disease field, including malaria, really wants to highlight that this is about resistance in treatments and how to prevent those for NTDs for malaria. So without any further delay, Karen, it's my pleasure to hand over to you. Thank you to the audience for being here. Thank you to our speakers. We really look forward to these discussions.
Thank you so much, Marianne, and to the International Society for NTDs for giving us this opportunity to highlight what a big burden anti-malarial drug resistance is, not just in Southeast Asia, but increasingly in East and Southern Africa. I'm going to present on behalf of a consortium of people trying to provide technical support to the malaria programs in the 19 countries in East and Southern Africa. And I'm hoping by sharing our approach and learning from the approaches of the other speakers and from all of you in the discussion, that we can tackle this problem more efficiently, more effectively, and more cost effectively. So our consortium is focused on trying to make sure that evidence informs policy and practice and has public health impact. I think many of us working in academic spheres are used to the publication being at the end of the cycle. And I think this consortium is to try and drive that cycle further to end up with actions being taken by policymakers and then healthcare workers being better informed and together tackling drug resistance. There are 4 components of our work, and the first part of our work was to try and collate the available evidence on antimalarial drug resistance across our region. And this was expanded thanks to a meeting organized by the World Health Organization in Uganda just over a year ago, where a lot of the malaria programs said, well, actually, their needs are more than just evidence synthesis for individual countries. They want to see what's happening on their borders. They want to be able to share evidence with their ministers, with their funders, about the distribution of resistance, which is never just a national issue. They also felt they didn't have easy access to the tools that they needed to detect and to respond to resistance. And they wanted a one-stop shop where the key information that they would need to get, if they suddenly were called in to make a presentation, they could take a few screenshots and summarize what they need to know. And so thanks to the works of Eulambius Mlugu and Stefanie van Wyk, who I hope are on the call and hearing themselves being acknowledged, they added deliverables to our grant. Stefanie created a chatbot called MoxieBot to help users find the resources and tools that they needed to detect and respond to drug resistance. Eulambius created a regional report which has informed an action plan, which I will be mentioning further just now. And Stefanie worked with Isher and Socharan from the Medical Research Council to create this dashboard to summarize the level of the problem that we are facing at the moment. It has been, I think, under-recognized the extent to which drugs are starting to fail in Africa. There are 4 countries that have the efficacy of their first-line treatment, artemether lumefantrine, below the WHO target of 90%. That's Angola, Democratic Republic of Congo, Kenya, Uganda. There are 8 countries whose data is outdated, so there are probably more countries that by now have also developed resistance. And we have molecular surveillance that Jaishree will be telling you more about, that shows that molecular markers of artemisinin resistance that have been validated or considered candidate markers by the World Health Organization have been detected in 12 of the 19 countries in our region. And in 7 of those countries, they exceed the concern threshold of the WHO. That's Kenya, Mozambique, Namibia, Rwanda, Tanzania, Uganda, and Zambia. And yet again, there are 3 countries that have absolutely no data on the efficacy of their first-line treatment. So that's a gap we need to fill. A lot of our work is working on addressing evidence gaps. And one of the things that we are doing is to try and better understand what the clinical significance is of the mutations known to be associated with artemisinin resistance. And that's slow clearance of the malaria parasite, and then you get reduced treatment efficacy, you get increased transmission, conferred by increased gametocyte carriage, and more infectivity to mosquitoes. The last time this analysis was done, there wasn't any artemisinin resistance reported outside of Southeast Asia, and the data available from Africa, where we have 95% of the world's malaria burden, only made up 3% of that analysis. With the good work being done by the team at WARN, we are now seeing that of the 93 eligible studies that will be eligible for inclusion in this analysis, almost half of them come from Africa. The other really important part is to make sure that being able to define the distribution and the prevalence of resistance and be able to explain to policymakers and the public why it's significant and why we need to act now is to bring people together and to build consensus on how to respond to drug-resistant malaria in Africa. In the photographs you are seeing here, this was a consensus-building meeting. It was the first meeting in East Africa on antimalarial drug resistance, which only took place this year. And if you bear in mind how many countries I described as already having worrying levels of drug resistance, it's an action plan that needed to be developed probably yesterday. But it's great that we've got everyone in the room, hosted by ourselves and the East African Community Secretariat, reaching agreement on the action that needs to be taken across the East African region. It's not a single country problem, it's a regional problem. And lastly, we want to reach healthcare workers with tools that make their job easier. We want to help them make evidence-based decisions in ways that are easy to understand. And we want to be able to support national malaria programs implement more complicated treatment guidelines than they've had to do in the past. Previously, you would have the whole country on one drug until that drug died, and it would be replaced by another drug. Now we've got more granular data. We show we've got efficacy in one area, but resistance in another. And countries are starting to develop quite complex plans with multiple first-line treatments, with different first-line treatments in different population or in different parts of the country. So having useful tools that can make it easier for them to train and support their healthcare workers is hopefully going to help make the implementation more effective. So lastly, a summary of the outputs that we hope to achieve through working together across the region is the synthesis of drug resistance, expedite evidence sharing, and we're really chuffed. We had hoped to achieve 8 countries sharing unpublished data within a year of it last being collected. Of the last sample being collected, we already have 7 countries that have achieved that target. And we are only 18 months old, so it's been good progress to date. Arjan, who's on this call, is going to be helping 4 of these countries develop a costed action plan so that they can implement efficiently and cost effectively the changes that need to be made to respond to drug resistance. And lastly, we'll be helping 2 countries with those digital and dynamically updated guidelines. So it just remains for me to say thanks to everyone in the consortium for getting us as far as this in the first 18 months, and to hand back to the next presenter. Thank you so much.
Thank you so much, Karen, and what an amazing way to start this webinar and this session. We have so much to learn from you. Clearly working on all sides of the equation, all from the surveillance all the way down to the capacity building at the healthcare, primary healthcare level. So a great inspiration from your group. Thank you so much for setting the scene. And as you've just said, now time to hand over to you, Professor Marc Mendelson. why is antimalarial resistance a blind spot in this AMR agenda?
Thank you. Thank you indeed. And it was wonderful to hear Karen's remarks. Being named Mark, this is the first webinar I've ever been on. There's actually Consortium is named after me, so thank you for that as well. But seriously, I was asked to really think about antimalarial resistance in light of AMR in general, antimicrobial resistance, and why is it a blind spot in the antimicrobial resistance agenda? And in the next minutes, I just want to share some thoughts, and there's some similarities with antimalarial resistance issues and sort of mainstream AMR. But why is there this blind spot, if indeed there is? So, as we've heard, this is, as you know, this is World Antimicrobial Resistance Awareness Week. And in fact, this is the first year that there's really been a very focused effort to include antibiotics, antivirals, antifungals, and of course, antiprotozoals, antimalarials in this celebration or focus on this problem. And one of the main problems, I think, for antimalarial resistance is that when people have talked about antimicrobial resistance to date, they're really talking about resistance of bacteria to antibiotics. And some of the reason why the focus is on there is justifiable. We are facing it is not an understatement to say that this issue of bacterial resistance to antibiotics is an existential crisis. It affects all of us in a most significant way. It affects food and our socioeconomic security. And with the IHME data showing, or estimating that in the next 25 years, there will be 39 million deaths from antibiotic resistance in bacteria, you can understand the issue. But more importantly, it's the loss of modern medicine. It's a loss of safe surgery, cancer care, transplantation, and start taking for granted. You need healthy animals for food security, and the loss of livestock is estimated to cost by 2050 950 billion loss in global GDP. And importantly, particularly as AMR in antibiotic resistance falls on low middle income countries, and particularly in Africa, we're going to be seeing an additional 28 million people being pushed into extreme poverty. So the focus has been very much on bacterial resistance and antibiotics. So how does one incorporate antimalarial resistance more into the global policy discussion of what we will now call AMR? And now I'm talking really about the whole umbrella term. Well, one of the problems we've had with antibiotic resistance is that in helping people to understand, both citizens, but even important people in government outside of ministries of health, is that we frame this problem as a microbiological construct rather than a human need. And the recent United Nations General Assembly political declaration on antimicrobial resistance really pushed this concept of sustainable access to effective antibiotics. And indeed, one could frame antimalarial resistance as the sustainable access to effective antimalarials. And by so doing, it brings in all different strands that are needed to sustain that access and to make antimalarials effective. And that in infection prevention, and it brings in research development, etc. So I would say that one of the issues is that we reframe the way we talk about resistance, be it antimalarial or other. I do appreciate that the model for neglected tropical diseases in terms of funding for research and development, in terms of product development partnerships, is somewhat different from bacteria and antibiotics. If you look at the global antimicrobial research and development investment, really since 2017, you can see that the majority goes to basic science and therapeutics, and really that's the antibiotics. Very little in comparison goes to diagnostics or to vaccines. And there is an opportunity to try and push further research and development, which might have a greater impact on the role of pharma. But what's actually driving the investment? I'd say to you that in antimicrobial resistance in general, what is driving certainly bacterial and fungal research and development are the World Health Organization priority pathogen lists, more so the bacterial pathogen list, which you see on the left, and the fungal pathogen list. But the problem is, the issue is that not all priority pathogen lists, in terms of the country context, are created equal. So if you think about the WHO bacterial priority pathogen list on the left, which is what I've shown you, this is the list of bacteria and their resistance mechanisms. But an African country with a high burden may look completely different. The critical group of pathogens and resistance now may be Neisseria gonorrhea, because you have HIV. An untreatable Neisseria gonorrhea, the threat would be increasing transmission of HIV. Salmonella typhi is far more important, one would say, on a programmatic level than the sort of bacteria that you see in tertiary academic teaching hospital ICUs, where the WHO bacterial priority pathogen list sits. Now, if you become agnostic for microbe and you actually say, well, what could South Africa's needs perhaps be? And in the critical group, I've added falciparum, Plasmodium falciparum, because we're trying to move towards elimination in many countries. So anti-artemisinin resistance becomes a critical issue, as is HIV, Mycobacterium, etc. I think what's driving R&D and a lot of the world attention are these priority pathogen lists, but they're not based specifically on public health needs. They're based on research and developments for new molecules, and that's not right. Now, malaria point-of-care diagnostic tests, this audience knows, has really transformed the landscape for reducing inappropriate anti-malarial use. Unfortunately, also increased antibiotic use, because if you don't give them an antimalarial, you don't have tests like this really in the field at the moment, so everyone gets an antibiotic. But that's not your problem, that's mainly our problem. But I think where antimalarial resistance and perhaps the malaria field is lagging behind is in the ability not just to diagnose through a test, rapid diagnostic test, the microbe, in this case malaria, but its resistance profile, as we can now, really almost at point of care or point of care for Mycobacterium tuberculosis, and even for bacterial infections. The Longitude Prize, which was awarded this year, is a rapid test for urinary tract infection. Urine goes onto the cartridge. The cartridge has microfluidics. It's able to sense when bacteria are there or alive. It can tell you the bacteria. But importantly, some of those channels have antibiotics, and therefore it can tell you whether they are working against the bacteria or not. And therefore, this sort of step forward in terms of diagnostics and allowing potentially point of care diagnosis of the right antibiotic to use in the resistance profile. This is the sort of thing you need at the bedside, I think, to improve antimalarial care and identify resistance. So I'm going to end with this quote, and I apologize, it's not meant to offend anybody, but it just seems to me that most times for any infectious disease is when things look as if they're coming to the end. And as we move toward elimination with that hope, we know that now with artemisinin resistance, this is, an increasing problem. But it reminds me of this quote from Senator Charlie Wilson, which related to America's huge funding of actually the Taliban to oust the Russians. For a moment, obviously supporting that. But as a construct, what happened was that they ousted the Russians, but America were not willing to put any funding towards the the rebuilding of Afghanistan. And this sort of reminds me with the elimination of malaria, that wonderful things were happened. They were glorious. They could change the world, and you could change the world with their elimination. And then we messed up the end game. I think that's something I think quite a lot about at the moment in terms of malaria, but also in other areas. So I hope these thoughts have been perhaps different from just purely on the antimalarial resistance area, but I think we hope to bring you some context with the antimicrobial resistance, high levels of policy thinking at the moment. So thanks very much.
Thank you very much, Marc. And really interesting and important to shine the spotlight much more on this really important pillar, in addition to robust surveillance, in addition to finding new treatments, but just really to be thinking about developing alternative strategies as one of the tools in the toolbox to slow down AMR resistance. So thank you very much for bringing that wider context. But speaking about robust surveillance and taking a closer look at that, it's my pleasure to hand over to you, Jaishree, and hear about some of the lessons in the post-COVID era about how molecular surveillance could really help with antimalarial resistance.
Thank you so much. And hopefully you can see the slides and it's all good to go. Right.
There we go.
Perfect. So thank you very much for inviting me to speak. And it's a hard act to follow both Karen and Marc, but I'm going to try my best. And I am going to be talking to 2 points that they both raised, was the need for surveillance and trying to have more data that was relevant to drug resistance as soon as possible. Obviously, unlike TB, we don't have a point of care diagnostic at the moment, but I think we're getting closer to generating drug resistance data on a more real-time basis. So let me start with my presentation. And it's really quite strange to start this off by saying that there was a positive impact from COVID, because as we know, it was quite a devastating disease that affected the whole globe. But one of the most positive things from COVID for Africa was particularly the development of next generation sequencing capacity on the continent. Pre-COVID, there were only really 7 public health laboratories that had NGS capacity. And after COVID, by 2022, that had increased to 31, and now it's getting closer to 40. But though this next generation capacity has increased in public health facilities, it really hasn't translated in many countries to being used for public health gain for malaria, and that is quite concerning. And to illustrate these, I'm going to show you the threat maps that are generated by the WHO in terms of malaria. So on the left with the red dots is showing the surveillance for HRP2 deletions, which is associated with the ability of rapid diagnostic tests to detect falciparum malaria. And as you can see, there's very limited data in Southern Africa. And it's a similar picture for monitoring the mutations that are associated with artemisinin resistance. And I think it's really very sad to see that next generation sequencing capacity has increased in public health across the Southern African region, but it isn't being used to inform policy decision-making for malaria. And the reason that it is becoming more important, as Karen highlighted, is that there are countries in Africa where we definitely have parasites that are resistant to the artemisinin component. And we have that in 2 clusters. We have it in Eritrea, Ethiopia, and Sudan, where we've got one set of African parasites that have become resistant to artemisinin. And then we've got another cluster of parasites as well in East Africa and Central Africa. So we've got Uganda, Kenya, and Rwanda, where they very clearly have shown parasites are becoming resistant to the artemisinin component. And if that's not concerning enough, once these parasites become resistant to the artemisinin component, they also seem to carry the mutations that are associated with being able to evade being detected by the rapid diagnostic test that is very specific for falciparum, which is the HRP2 deletion. So this has really given us a real need to strengthen our surveillance systems across the countries in Africa, because we have got African parasites that are developing on the continent and are spreading and becoming entrenched. And if we really want to get to that fantastic goal of eliminating and eradicating malaria, we need to make sure that we don't have drug and diagnostic resistant parasites entrenched on the continent. So it is really critical in Southern Africa, particularly, to have very strong surveillance for two main reasons. And I think it's like the rest of Africa, but particularly in Southern Africa, there is a high level of interconnectedness between all the countries. And this is either through formal borders. So we've got some mapping of using a cell phone movement across the borders. And these are through formal borders. And you can see there's a lot of movement across the region. And there's a picture showing you a border between Mozambique and one of the provinces in South Africa. It's just a little wire fence with a little bit of opening, and people just cross this border with no checks on a daily basis. And as we saw with COVID and with many other infectious diseases, mobile populations carry infectious diseases with them. And this really is a high risk in the Southern African region, where we could get the importation and the movement of drug and diagnostic resistant parasites into Southern Africa, which would really hamper the elimination goals of the region. And we've seen this movement of drug resistance parasites previously. These weren't parasites that came from Africa per se, but they arose along the Thai-Cambodia border, which Arjen is going to talk about a little bit later. But they entered through the Horn of Africa and spread through Africa through human movement. And we've seen that both with chloroquine and then with sulfadoxine pyrimethamine resistance. So we've seen this picture before. We know what's going to happen, and we really need to prevent it. And one of the best ways to do that is to have very strong surveillance so that you can put in mitigation measures before you have a drug or diagnostic resistant outbreak. So talking to that was something that we tried to do, was to generate a use case scenario for doing molecular surveillance at a regional level, so that we could inform policies across the region. And this was done in the Elimination 8, which is 8 Southern African countries: Angola, Zambia, Zimbabwe, Botswana, Namibia, Eswatini, South Africa, and Mozambique. So we've got 8 Southern African countries that are all working towards elimination. So to make sure that it had public health impact, it was malaria control programs were involved in designing what we wanted to do, what we wanted to look at, and how the data was generated and shared. And it was done in collaboration with the National Public Health Institution in each of the participating countries. Although it was open to all 8 countries in the E8, unfortunately, both Botswana and Zimbabwe chose not to participate. And I'm going to show you what consequence that had. So as part of this genomic surveillance initiative on a regional basis, on a regional level, we had samples that were collected across this region, and we were going to assess them for drug and diagnostic resistant markers. So the markers that we looked at were obviously for those associated with artemisinin resistance. We looked at a previous drug that had been used previously quite strongly in the region, which was chloroquine. Also looked at sulfadoxine pyrimethamine, which is used in certain countries for chemo prevention measures. And we've looked at mefloquine and peploquine, which are 2 other drugs that might come into the region at some later stage. So during this initiative, which was conducted during the 2023-24 malaria season, over 4,000 samples were sequenced using a next-generation sequencing assay from 5 of the participating countries, which were Angola, Eswatini, Namibia, South Africa, and Zambia. And we generated data. And I think it gave us a real pause for concern once we saw the data that was generated from the initial. So this is preliminary data. We haven't finished the analysis, but it does give us an indication of the value of regional surveillance and the response required. So in terms of artemisinin resistance, where you look at the CALCH13 mutations, there is definitely a north-south divide. So the countries towards the north, which would be Angola, Zambia, and Namibia, have a high prevalence of candidate markers that are potentially associated with drug resistance, artemisinin partial delayed clearance. And quite interestingly, then you've got Eswatini and South Africa, which are much lower down, have very limited number of isolates with any mutations. But what we don't know is how far these parasites have moved, because we've got no data from Botswana and Zimbabwe. So we do know that there are parasites increasing in terms of resistance markers in the Southern African region, but we don't know how far south they've moved. So, you know, South Africa really, while we are happy that we have very limited resistance markers at the moment and our drugs are very effective, we're not quite sure how long this is going to last and how quick we need to respond, because we can't tell how close to us the resistant markers are coming. Then if you look at sulfadoxine pyrimethamine, so as I said, this drug is no longer used for treatment, but it's used in some of the countries in Southern Africa for chemoprophylaxis. And again, you see this gradient of resistant markers. In Angola, where the drug is not used that heavily and hasn't been used previously, they've got a very high level of very sensitive parasites, whereas in Eswatini in South Africa, we've got very, very resistant parasites, though the drug is not used. And this is really a consequence of regional pressure because, as I said before, SP is used for chemoprevention measures like seasonal malaria control. So the high level of resistance is definitely giving you an indication that SP might be reducing in its efficacy for seasonal malaria control interventions in the region. So it's something that needs to be monitored. In contrast to where we see for sulfadoxine pyrimethamine a high level of resistance, quite interestingly, for chloroquine, it seems the parasite has reverted to being really very highly sensitive to chloroquine. And you've got generally the parasite across the region is very sensitive to chloroquine or has none of the markers associated with chloroquine resistant, with exception of a few clusters in Angola. And that must be just from chloroquine pressure coming from the DRC. And I think last and not least, this genomic surveillance, the other thing besides giving us information on drug resistance, it confirmed what parasite strains and species we have circulating in the region. And I think this finally, gave us some clarity on what species there are and what sort of drugs and what types of diagnostics we could use. So in terms of the most common species that we found was falciparum, which I think we all know in Southern Africa that tends to be the most common species. We didn't find any vivax infections, which is contrary to a few reports that have come from Southern Africa, which is reporting an increase of vivax infection. Definitely there's a much higher prevalence of ovale and falciparum in the 3% of co-infections. But this definitely gave a lot more confidence to the countries to keep on using rapid diagnostic tests that detected falciparum mainly because we don't have many of the other species moving forward. So I think I'm hoping I've convinced you in this is that it showed the value of having regional surveillance for evidence decision making that would have an impact on a region trying to move forward towards elimination. It also highlighted the need for prompt data sharing across the border, because if you have resistant parasites on one side of the border, it's very likely they have moved across. And I think also this project also highlighted the importance of having regional hubs. While it is great that every country has NGS capacity, it is very, very costly. And we do know that malaria programs have limited budgets. So I think to use your funds effectively would be to exploit regional hubs, because there's economies of scales, especially when it comes to next generation sequencing. And also you need specialized human resources, not specifically in generating the data, but definitely for downstream bioinformatic analysis. And that is as a scarce skill on the African continent. And I think if you have regional hubs that have centers of excellence with genomics and bioinformatics skills, we would have much better outcomes from regional surveillance. Also, if you do regional surveillance, you can generate data at a regional level that is comparable and that is giving you the same methods and measures, because you have standardized protocols on the way you are analyzing your data. And so it's equal across all countries who have submitted data. And I think just looking at when I was doing the final preparation for this talk, came one of the action points from the recent COPE conference, which just emphasized the need to have genomic surveillance put as part of core to all our public health interventions, because it's unclear what climate change is going to do in terms of the spread and evolution of infectious diseases, but we certainly feel that it's going to have some impact on malaria in terms of the spread, of how far malaria is going to be, and possibly driving forward and accelerating the speed at which you have drug and diagnostic resistance developing and spreading. So I think it's really very important that we hone in and strengthen genomic surveillance at a regional level, if not at an individual country level, to make sure that we can have evidence-based decision-making. And with that, I'd like to thank you.
Thank you very much, Jaishree. What an amazing presentation. And thank you so much for reminding us of the power of regional collaborations, particularly in an area like Africa, where the population is so young, social and mobile, and really giving us a blueprint of how to roll out this surveillance, including very difficult issues such as data sharing and so forth. So we really look forward to hearing a lot more with your guidance and expertise, and thank you for that. Following this amazing presentation, I'd like to hand over to you, Leah. Leah, you'll be taking us through how to do therapeutic efficacy studies, but also, all importantly, how to link those to the policy agenda. Over to you. Thank you, Leah.
Thank you so much, and thank you so much for having me. So I'm from the President's Malaria Initiative based at US CDC. And before I get into it, I will talk a little bit about what PMI is and why we care about therapeutic efficacy monitoring. So the President's Malaria Initiative, or PMI, is a presidential initiative that began in 2006. And we have 30 partner countries around the world, malaria endemic countries, 27 of which are in sub-Saharan Africa. PMI's programming is holistic, so we support all areas of malaria prevention and control, including procurement of commodities like mosquito nets, insecticides, rapid diagnostic tests, and medicines. And we also support interventions like social behavior change and community and facility-based testing and treatment for malaria. PMI is one of the largest procurers of ACTs for Africa. So in 2023, we procured over 62 million ACTs. Since PMI's launch, we've procured almost 1 billion malaria treatments. So just to say that PMI has a vested interest in ensuring that the millions of ACTs procured for Africa are effective in treating malaria and saving lives. So there are 6 ACTs recommended by WHO. Just to note that artemether lumefantrine, that Karen talked about in her presentation as well, it comprises 85% of donor-funded procurement and is really the principal ACT on the market in Africa. The remaining 5, we have artesunate and midazolam, and then artesunate pyronaridine, which is one of the newer ACTs, that's quite a bit more expensive than AL or ASAQ, almost 2 to 3 times. Artesunate mefloquine, which is not really used in Africa very much, and then artesunate sulfadoxine pyrimethamine, also not used very much in Africa due to the SP component being used for pregnant women and seasonal malaria chemo prevention. And I realized that I only have 5 here. We're missing one, dihydroartemisinin piperacin, which is longer lasting and also quite a bit more expensive when compared to AL and ASAQ. So how do we monitor for ACT efficacy? So we do this through therapeutic efficacy studies, or TES, which are prospective clinical trials in which patients presenting to a health facility with uncomplicated malaria are recruited, administered treatment, and followed up for over 4 to 7 weeks, depending on the drug. And then we follow their outcomes. So including whether and how quickly parasitemia decreases in the first 3 days post-treatment, and if they present to the health facility in the following weeks with a malaria infection. And what do these TES results tell you? So there are three principal things that we look at. The first is partial artemisinin resistance, or does the ACT rapidly reduce parasite burden as expected? And that's when we're really looking at the first 3 days of follow-up post-treatment. And the second is uncorrected efficacy, or does the patient remain parasite-free after taking an ACT? And uncorrected efficacy can be considered to be the initial canary in the coal mine for declining partner drug efficacy, often preceding a decline in the corrected efficacy by years. So unlike the case of the next metric, there's no established threshold of concern, but it's more of a qualitative interpretation. And then we have PCR corrected efficacy. So we remove the patients who were infected with a new infection during the follow-up period from the analysis to answer the question, does the ACT cure the infection that the patient initially presented with? A PCR corrected efficacy of below 90% is the threshold at which the WHO recommends a change in ACT. So what do these look like in Africa? So first, to look at partial artemisinin resistance. So this is the term used for failure of the artemisinin component of ACTs and has a strict definition from WHO. So partial artemisinin can be measured with a TES, and it manifests with increasing day 3 slide positivity and delayed parasite clearance. Mutations in the PFK13 gene can be used to confirm partial artemisinin resistance. So in the map on the right, I've shown countries that meet the WHO criteria for confirmed partial artemisinin resistance. And as you can see, the focus is around the Great Lakes region and the Horn of Africa. And then to look at our second metric, uncorrected efficacy, and we'll focus here on artemether lumefantrine. And so uncorrected efficacy, and Karen mentioned this too in her presentation. We've indicated the countries that have reported TES with an AL arm that has had an efficacy below 70%. In some of these countries, like Uganda, Burkina Faso, and DRC, AL efficacy has been routinely reported to be around the 50% range. So this means that half of all patients come back with malaria within 28 days of AL treatment, which is a concerning figure that speaks for itself and really shows that there's little post-treatment prophylactic effect of AL. And then we have corrected efficacy for AL. So this is the gold standard indicator in the TES. It's the proportion of patients that are cured by the ACT treatment. In the ACT era for ACTs, the corrected efficacy is largely driven by the partner drug efficacy. As such, low corrected efficacy is usually an indicator of declining partner drug efficacy. There's a well-established criteria for stating that the drug is failing. So this is the 90% threshold that WHO says to change ACTs. So in this map, we've denoted all countries where an AL arm has had a corrected efficacy below 90% in a TES. One thing I want to draw your attention to again is that these findings are not one-off. For example, Burkina Faso has had 7 TES sites with an AL corrected efficacy of below 90%, and Angola and Uganda have reported it 4 times. So putting it all together, we have countries with confirmed partial artemisinin resistance, AL corrected efficacy under 70%, and AL corrected efficacy under 90%. And we have these 2 countries, Tanzania and Uganda, that have had concerning findings using all 3 metrics. So what do we do with these findings? First, there's the WHO strategy that was published in 2022 that gives countries in Africa guidance of how to prepare for and respond to antimalarial resistance. It has 4 pillars. The first is to strengthen surveillance by doing things like TES and molecular surveillance that Jaishree described in her presentation. 2 is to optimize the use in diagnostics and therapeutics preemptively. Pillar 3 is the response to resistance by limiting the spread of resistant parasites. So, and then the 4th is research and innovation. PMI has taken this guidance and built on it to give some specific quick actions that countries can take depending on their status. And much of these actions are short-term and really focus on ACT diversification strategies. So just to go through this, we have countries in green. So this is without evidence of partial artemisinin resistance or partner drug declining efficacy. And right now, this is most countries in Africa. So the goal here is really to prevent the emergence of resistance by diversifying the ACTs used. And you can do this by using multiple first-line therapies in a country and can include AL as a component, as there's been no issue with lumefantrine. In the light yellow, we have countries with evidence of declining AL efficacy, but no partial artemisinin resistance or evidence of it. And here the goal is to mitigate the consequences of AL resistance, so preventing further poor treatment outcomes and prevent resistance to artemisinins or other ACTs. And we also here want to protect lumefantrine for future use for medicines that are coming on the market soon, like triple ACTs that include lumefantrine. The actions here are to use multiple first-line therapies, but without using AL as a component. In the darker yellow here, we have countries with evidence of partial artemisinin resistance, but high partner drug efficacy. So here we want to prevent or slow the spread of partial artemisinin resistance and prevent the emergence of partner drug resistance by diversifying the ACTs. So here, really, the options are to intensify malaria control using multiple first-line therapy and can include AL, and doing other transmission blocking activities like considering the use of single low-dose permaquin. And in countries in red, so here we had, as I pointed out, we have Uganda and Tanzania that have both evidence of partial artemisinin resistance and declining AL efficacy. And here we want to mitigate the consequences of AL resistance, like poor treatment outcomes, prevent or slow the spread of partial artemisinin resistance, and again, still protect the lumefantrine for future use. So here we'd recommend to immediately switch away from AL and then introduce multiple first-line therapies without AL. And then it's the same as the previous category, consider transmission blocking interventions such as single low-dose permaquin and intensifying malaria control. And here, just to show a map on the right of PMI support for therapeutic efficacy studies. We support TES in almost all PMI partner countries. And we in our technical guidance, we echo the WHO guidance that have to implement 1 TES every 2 years, representing about 4 to 8 sites. And we do a lot of this, much of this work through the Partnership for Antimalarial Resistance Monitoring Africa, or PARMA. And this is a PMI-initiated activity with a vision to diagnose and treat every malaria case in Africa with effective diagnostic tools and antimalarial drugs. And we do this in 4 ways. So first, we generate timely and accurate antimalarial efficacy information by implementing TES. 2 is that we conduct surveillance for molecular markers of resistance through complementary studies. The 3rd is to enhance African malaria investigators' ability to independently conduct drug efficacy studies and perform the corresponding laboratory work. And the 4th is to connect antimalarial resistance efficacy and resistance stakeholders to share information, insights, and opportunities, much like the webinar we are at today. And that is what I have for you. Thank you so much.
Thank you so, so much. And how interesting to hear and see in that really clear traffic light system, not just what diversification strategies must look like, but also how to really make that easy for policymakers to uptake and implement. So thank you. We have much to learn from that across all NTDs, I'm sure. And in the name of collaboration and education and just really learning from each other, it's been wonderful to have this amazing focus and spotlight across the African region. But I think it's time to welcome you, Arjen. Thank you so much for joining us. You're actually going to be giving us an insight from a completely different area of the world, from the Greater Mekong subregion. What are the regional initiatives there for fighting antimalarial resistance? Over to you. Thank you, Arjen.
Thank you very much for having me. So I thought I give a very brief overview of the journey that the Greater Mekong subregion has gone through over the last 15 years to contain antimalarial drug resistance here in the region. So the region here has a bad reputation of being the cradle of antimalarial drug resistance. So chloroquine resistance started here, pyrimethamine resistance started here, artemisinin resistance started here. And can you show the slides also, because I don't
Absolutely.
see them.
And just in case any of our audience was wondering, your sound is going up and down a bit, Arjen, but I think in our tests we came to the conclusion that it will just very shortly, within a matter of maybe seconds, reconnect properly. So I'm just going to let you continue, but it was just to reassure the audience as well. And yourself that
apologies for that.
No, not at all. We can hear you and it will come back properly. Thank you. Sorry about that.
So 15 years ago, we described artemisinin resistance for the first time in Western Cambodia, where parasite clearance, instead of 10 to the 4th times less every 48 hours, it was only 100 times reducing every 48 hours. And it was shown that it was mainly the ring stage of the parasites, of the asexual Plasmodium falciparum parasite, that had become resistant. We were wondering what that would happen for efficacy of the artemisinin combination therapies, the first-line therapy for falciparum malaria worldwide. As such, if you only have artemisinin resistance, the combination, if you have an effective partner drug, is still quite good, just a little bit reduced, but it facilitates the development of partner drug resistance. And that's what we observed in the Greater Mekong subregion. For instance, with artesunate mefloquine on the Thai-Myanmar border, there was mefloquine resistance, but artesunate mefloquine was very, very effective until artemisinin resistance emerged, and then mefloquine resistance increased very rapidly, and the combination became useless. And a similar observation was made with DHA piperoquine in Cambodia. So everyone was then very concerned, and the ACTs started to lose their efficacy very rapidly in the Greater Mekong subregion, which comprises of Vietnam, Cambodia, Thailand, Laos, and Myanmar. So in Cambodia, 4 of the 6 ACTs were becoming much less efficacious. Everyone realized that action needed to be taken, and there was high-level political support to attack this problem. The WHO was very actively engaged, and it was realized for the Greater Mekong subregion, where malaria transmission is not very high, so 1 infectious bite per year on average, compared to one infectious bite per day in many sub-Saharan African countries, that you have to eliminate falciparum malaria if there is ongoing drug pressure from the artemisinins, if you want to get rid of artemisinin resistance. So there came an malaria elimination program for the Greater Mekong subregion that was supported by all the Greater Mekong subregion countries. And then there came a big game changer, which was the large Global Fund regional grant for attacking artemisinin resistance in the Greater Mekong subregion and malaria elimination. So that started the first round in 2014, and it's currently in its fourth round already. More than $700 million have been spent on this. All the countries working together in this regional artemisinin resistant initiative, or RAI, or we call it now RAI-E, because it is aiming for elimination. And the main components of this big program is the collaboration between the 5 countries, both the implementers, so the national malaria control programs, the different NGOs, but also the private sector is collaborating there. They work together, they grew together also a lot over the years. It was very nice to observe that. There was strong technical support from the WHO, but also from academic partners. There was high political support. So in Southeast Asia, we have APLMA, the Asian Pacific Leaders Malaria Alliance, the ASEAN, political backup, and also all the funders, global funds, but also other funders were collaborating here. The program itself, what was really a game changer there was an implementation of village malaria workers in all the villages where malaria was endemic, supported by the grants, well supervised, well organized. So they were there for surveillance, including, by the way, molecular surveillance. Village malaria workers collecting filter paper blood spots that are then sent to central labs for molecular surveillance. The distribution of long-lasting insecticide-treated nets, but especially also early diagnosis and treatment of malaria, both falciparum malaria and vivax malaria, which is also a problem here in the region. And there was a rollout of primaquine for the radical treatment of vivax malaria. Those interventions were already very effective, and to get rid of the last remaining foci of malaria transmission, so-called last mile interventions were tested and implemented. So targeted mass drug administration, targeted chemoprophylaxis in forest goers, I have a few more slides on those, and active case detection in target populations. So here's an example from Myanmar, where you can see how effective it is to set a well-functioning village malaria network in a region in Myanmar. And on the left side, you see falciparum malaria. Oh, no, that's vivax. Yeah, left is falciparum malaria, right is vivax malaria. How quickly that goes down by just implementing a very effective village malaria worker network. But then if you reach elimination levels, to keep them relevant, the village malaria workers, they have to expand their service package. Otherwise, patients with the fever don't go to the village malaria work anymore when they only treat malaria. So in Myanmar, the package was expanded by for the diseases you see listed there, and then it was noted that the uptake of the services went up again to very good levels, as you see on the right-hand graph. And that again was very effective for the elimination of malaria. And this is probably one of the lessons that could also be useful in sub-Saharan Africa, to put a larger emphasis on community health workers and village malaria workers. Then mass drug administration, when malaria transmission is going to very low levels. If that is combined with mass drug administration in target areas, that is also has proven to be a very effective way for malaria elimination in these settings. And then the last foci of transmission in the area here are in the forest, and forest goers are the last groups that catch malaria. And if you give them chemoprophylaxis, this was a trial with artemether-lumefantrine, not the best drug to do this. It is now replaced with artesunate pyronaridine, but that was not available at the time of the trial yet. You can protect those forest goers from getting malaria. And then lastly, to address the problem of ACT failure, if you give triple artemisinin-based combination therapies, where you combine the artemisinin component not with one but with two matching partner drugs, that is very efficacious to treat multi-drug resistant falciparum malaria. But we think it's also a very good way to prevent the emergence and spread, especially also of partner drug resistance. And this might also be a very useful approach for sub-Saharan Africa. So what has this brought us in the Great Mekong sub-region? Well, in the eastern part of the Great Mekong sub-region, malaria is really being eliminated at the moment. This year in Cambodia, which has had all the huge problems in the past with drug resistance, not a single case of falciparum malaria has been reported. Laos is doing very well. Vietnam is doing very well. The eastern part of Thailand is doing very well. A big problem, unfortunately, is Myanmar, that since the military coup in 2021, the health system more or less collapsed, and malaria is coming back quite rapidly there, blousing over to neighboring countries. So that is a big concern at the moment. But the eastern part of the Great Mekong sub-region is eliminating malaria very successfully. So in conclusion, I think that the components that has been sort of piloted in the Great Mekong sub-region that could also be very useful for sub-Saharan Africa, where now artemisinin resistance is also emerging and spreading. This regional approach where countries work together, where they share their data, where they discuss problems, where they, especially the implementation strategies are being discussed and rolled out. I think, and also the governance system architecture that was tested out in the Great Mekong sub-region. I think that is something that could be looked at in detail for African countries also. So this multi-stakeholder regional approach where not only the implementers, but also the funders and the technical partners sit together. And then this big emphasis on community health workers for implementation and surveillance of malaria activities, I think is a very useful approach. The last mile activities that are very useful in the Greater Mekong sub-region, I think those have to be tailored. They will be different for high transmission settings in sub-Saharan Africa. Thank you for your attention.
A huge thank you from us, Professor Aryan, for ultimately giving us hope. The start of your talk really gave the dimension of the challenge that the Southeast Asia region has faced, and then some incredible results, but also really useful approaches and lessons learned for the rest of the world. So thank you so much. And also, again, a huge thank you to our speakers, all of you. Thank you. You have given us an incredible insight into anti-malarial drug resistance, but also what can be done. And I think that our audience, which is part malaria experts, part NTDs, will have drawn from every single aspect of that. So a huge thank you. And lots of clapping and thumbs up going on in the chat for all of you. So really a big thank you for that. And perhaps now we do still have a few minutes for some questions and comments. So if anyone in the audience wanted to ask a question, please, now's your chance to add it into the chat and we'll come back to that. And in the meantime, perhaps I could ask all the presenters to rejoin with their cameras, just to bring together all these really tremendous wealth of ideas that we've been hearing about, and perhaps just to tie this a bit to the neglected tropical diseases, the challenges faced in that field. Obviously a huge regional overlap in terms of the malaria burden and the NTD burden. And so I was wondering, out of the myriad of challenges that you see exacerbating anti-malarial drug resistance, what do those working on NTDs need to look out for? But also, what are the main lessons that we can draw from what you've been researching and overcoming, really? I'm not sure who would like to go first to answer that. Perhaps you, Karen?
So I think that there is so much overlap between malaria, the antibiotic resistance that Marc spoke about, antifungal resistance, and neglected tropical diseases. And I think that a lot of what we've been speaking about is how much stronger we are when we work together, because I think that a lot of the drivers are the same. Poor quality drugs, poor adherence. Diseases of the poor generally don't have the optimal formulations, the fixed drug combinations that prevent people from cherry picking and only taking part of a course or part of a combination. I think the threat of climate change is often spoken about as how these diseases will become more prevalent potentially, which is true. High temperatures, high rainfall will increase malaria, but at the same time, areas of drought will have the opposite effect on malaria. But a lot of that can also drive the refugee populations and massive movements of people. And I think what we're starting to see is when you have those massive movements of marginalized people, they're not just vulnerable to one or two diseases, they're multiple diseases and drug resistance to multiple diseases that all come into play. But always wanting to end, following Arjan's good example, on a message of hope. I can also see a fantastic opportunity for the village health workers to broaden their expertise. And we're starting to see very similar results replicated in Africa, for instance, in Rwanda, where village health workers are being trained and supported to not just treat malaria, because their malaria burden has gone down since they scaled up the use of village health workers, and now they're treating other diseases. And I think they can be treating schistosomiasis and other more common neglected tropical diseases. So I think there is a lot that we can learn from each other. And I think they reflect health systems problems, and they reflect the same marginalized, neglected populations suffering from these diseases. Thanks.
No, absolutely. I think one thing that this session has revealed is really how many touch points there exist for really intensified collaboration between these two fields. So it's very exciting. Would anyone like to add to Karen's comments?
Just that I agree with Karen that many of the drivers of the problem in malaria also apply to other neglected tropical diseases. So underdosing is a huge problem, always been in malaria, especially also, by the way, in the Greater Mekong subregion, for instance, where they added chloroquine to the sea salt, which was a great way to generate chloroquine resistance. Small children are often underdosed. Professor Karen Barnes, her very early studies have shown that. Then surveillance of antimalarial drug resistance, it made a huge jump when molecular surveillance became available. That might also be applicable to other neglected tropical diseases. But then also what actively you can do about it. So for malaria, these triple combination therapies, so combination therapy might also be a concept that could be wider applicable to other diseases. We already have it for HIV, for tuberculosis. It might also be applicable to other diseases. Over.
Well, and just kind of building on, oh, sorry, Mark, you were going to add to that? Oh, no.
No, I don't think there's much to add to it. I mean, I totally agree with both Karen and I. I think one thing we're finding is that you know, how do you communicate threat? And I think this is an issue for a lot of NTDs. I mean, historically we've tried to communicate things through numbers. You know, numbers of people who die, numbers of people affected. It doesn't seem to work, particularly as the numbers get very big. And in antibiotic resistance, you know, when you're dealing with 39 million or whatever it is, it disenfranchises people. So how do you use and the use of narratives, but also the use of the good news stories and the wins, as Aaron actually, you know, showed, and as Karen has showed, a lot of the translational work, what can, you know, really is to cut out, and that's I think a lesson for us all, and I think also in NTDs. So I think that's the issue, another issue, how we communicate the wins and how we try and move things forward in that area.
Absolutely, and with NTDs, of course, it's slightly different as well in many ways. It's not one disease, but more than 20. Also, the drugs are donated by, there's a really interesting ecosystem of partners between the drug donations. I think the NTD sector actually holds a Guinness World Record in number of treatments donated in a 24-hour period. And also, perhaps we haven't yet been looking sufficiently for any resistance, and maybe that would be a question for you, Jaishree, between a disease like trachoma, where an incredible amount of mapping has been done, to the other end of the spectrum, where a disease such as Chagas disease has anywhere under 10% of people affected who know they have the disease. I mean, it's very hard to know where it is, where we stand, how it's evolving. What might be your advice from your experience, where to start, what to strengthen first?
I think the main thing is surveillance, just to find out where you have the disease and get your burden. So, I mean, I think everything just underlines just knowing where the disease is and what the burden is, and what drugs are working where. So it really just comes down to surveillance and being able to map it, and everybody knowing what can be done, where. I think with the neglected tropical diseases, just by virtue of being calling that, people just don't know where it is, how prevalent it is, and how to effectively treat it. There's just very limited knowledge. So I think just having a combination of good surveillance to know where the diseases are, where it's mapped, and everyone is aware of it. I mean, even with malaria, as we can see, when the burden is decreasing, people tend to forget that the disease ever existed there and don't know how to treat it. So I think it's very much keeping any disease on everybody's mind, having the right guidelines, and having real up-to-date maps. So if somebody is going to visit there, even if they're not a medical doctor, they do know that there's a risk of that happening. It really just boils down to surveillance and just creating awareness around it.
Would anyone like to add to Jaishree's comments? I suppose I'd like to add to that one of the things I'm so sorry, Mark. I've got a tiny delay in my screen and I keep thinking I'm interrupting you. No? Okay, good. So just bringing in finally, Leah, your bridge between the science and the policymaker, and sort of that very impressive support that you're giving to really across the African region. And in terms of treatments, how can we leverage what you're doing for malaria treatments and policymakers? Is there any of that could be applied to NTDs? And even in terms of the treatments themselves, are there opportunities for repurposing? I think Karen touched upon that, but where can we apply these all important cross-sector gains?
Sure. Yeah, I think even within malaria, the biggest challenge to responding to these TES results have been the lack of availability of affordable medicine. So, as I mentioned in my talk, AL and ASAQ are really the only affordable drugs for Africa right now. So to diversify, we really need to work with the drug manufacturers and the R&D folks who are making new drugs to ensure that there are options when you do surveillance that requires some sort of public health action. So I think that's just one lesson that can be learned, and certainly does not just apply to malaria. I guess the other, just like antibiotic resistance, connecting between sectors with the malaria folks and the other NTD folks to see what drugs are being used, as they can, at best be complementary for if you start using something like artesunate-mefloquine for schistosomiasis. It could be, a double whammy in treating both infections. But at worst, if you're introducing more of the drug into the population, it could be a recipe for introducing more resistance. So definitely just a plug for communicating within ministries of health and across sectors.
Fantastic. That's a really important thing to look out for. So thank you for flagging that. There's a question here, thank you, from Tiff Damash, who's asking, so we looked at Africa, we broadened the lens with those all-important lessons from Southeast Asia, and Tiff Damash is asking, given the relationship between conflict and increased risk of AMR more generally, and the fact that conflicts seem to be on the rise in so many so-called fragile settings, could the speakers please touch on a little more on their experiences with targeting AMR efforts in active conflict regions?
Yeah, that is such a difficult question. I don't know who wants to take that one. The only useful thing I could say is, so in Myanmar, where this big problem is, that the areas where you had strong community health worker networks, they could keep operating quite independently with relatively little support and oversight. So to decentralize the care is one way to address it, but it is so difficult, and so much good work can be destroyed in a short period of time when when a war starts somewhere, or a civil war or internal conflict. So yeah, it's a difficult one.
It is a difficult one, and I agree. And I mean, from a bacterial point of view, you know, we've seen it. We saw it in Iraq. We've seen it in Ukraine. We're seeing it in Gaza. So one of the, you know, it's not only antimicrobial resistance, however, it's also just a lack of antibiotics. And again, it's about sustainable access to effective medicines. And that is challenged wherever there is a war or conflict situation. And the only thing one can try to do is, from that point of view, keep the channels open. I mean, we've touched a lot of, you know, this has been touching on antimalarial resistance and antimicrobial resistance. But from, you know, my area of work, we have to remember that more than each year of lack of access to any antibiotic than antibiotic resistance. And so it's all about, this is why the whole move towards sustainable access, including in conflict situations, I think is so important.
Would anyone like to add to that?
Perhaps just a short addition is I've been really impressed to see recently the excellent surveillance for resistant malaria that's taken place along refugee camps on the Ugandan border, and the different patterns that they pick up if refugees are coming from DRC or they're coming from South Sudan. And so I think that we mustn't be culpable and complicit in neglecting neglected populations. And I think that's where the work of MSF and other civil society organizations that determinedly will go into Gaza despite the hazards, I think is something that we can all learn from, acknowledge its difficulties, but not shy away from it, because I think the need there is greatest.
That's absolutely so important, and really not just in conflict and those extremely challenging environments, but just more generally in any resource poor area. So lots to think about there. And I'm looking at the time and I knew the 90 minutes would just fly by, because this has been such an incredibly interesting and useful and important session. We touched on everything from the genomics all the way to linking AMR to the policy agenda. And I think we did really fulfill the brief of World Antimicrobial Awareness Week, which was to raise awareness, but also foster really strong collaborations. And I feel like it's just the beginning of the conversation between the MERIA and NTD fields in this area. So we're really grateful for that. And really, I think the main thing was it was mentioned in the comment also to humanize the AMR concept in the same way that COP last year reminded us and firmly put on the agenda that climate change is actually a health problem, and AMR, it's not just an antibiotics problem, but it's really about public policy and public health in a very wider sense, and particularly in infectious diseases, there's much to do there. So a really complex, huge webinar. I think that to bring all this together, I'll hand over the final words to you, Professor Karen. What are the next steps? What do we need to look out for? And what are the main take-homes from today's discussions?
Thank you so much, Marianne. I hope I'm audible this time and not.
Yes.
So I think for me, one of the big take-home messages for antimalarial, antimicrobial NTDs is that we really need to find an advocacy path to get onto the WHO priority pathogen list. It's a bit of a mystery to me how one part of WHO will be highlighting what big problem NTDs are, what big problem malaria is, and yet they don't speak to those people when they set up those priority lists. And I think Marc illustrated that really beautifully. I think the other thing that we share with NTDs is the need for point-of-care diagnostics. If we had diagnostics, we would have much better targeted use of drugs and not the misuse of drugs that we often have when caring healthcare workers are unable to define what the cause of someone's fever is. And it would be the cherry on the top if we could have those diagnostics that can pick up for drug resistance as well. I think Jaishree's highlighted the value of regional initiatives and how important rapid data sharing is and the potential of regional hubs for problems that are shared across a region. I think that Leah has been a perfect example of responsible funding agency where you are not just supplying drugs, but you're active in making sure that those drugs are working, and you're active in seeking to change policy and practice, which I know you don't control single-handedly, when there are failures. And I think it's that cycle that too few people recognize. And I think starting to think of our work within a cycle is really, really powerful. And then lastly, I think Arjan has given us a ray of hope. I think we are dealing with many, many hundreds of millions of malaria cases compared to the 68,000 that the eastern Greater Mekong sub-region is being given over $700 million to tackle. So we're not going to have that per person kind of funding. But village health workers are probably the most cost-effective route for a lot of the fevers that are common in our environment. And great to see how that map, protect, test, and treat work was expanded to other diseases, including NTDs. So really, I think lots of lessons learned. And thank you so much to the International Society for NTDs for including us in your webinar series.
Honestly, the thanks is the other way. And I feel like there's a 90-minute session for each one of your topics. So we really hope to hear, have you back on very soon. Keep this collaboration going. Victor Aswa is writing great talks. Many thanks to the speakers, echoed by Alex Ahibwa. Wonderful talks. Thanks to all the speakers for sharing. Stephanie Van Wyk saying thank you, ISNTD. Big thanks to Marc, SE Africa too. Thank you for the great talks. And thank you, Stephanie, so much because you were an very important part of organizing this session today. It's been an absolute pleasure. And so I'm sure the audience joins me in a final very warm round of applause and another huge thank you. And certainly let's please keep in touch until next time. And from us here at ISNTD, all the best to the audience and all the best to you as well, dear speakers. Thank you.